Doctor dismisses black woman's pain, horrified. When she's the hospital chief. Dr. Mitchell looked at the black woman doubled over in pain and sighed dismissively. "It's probably just anxiety," he said, not even bothering to run proper tests. But when security tried to escort her out and her hospital ID badge fell to the floor, the entire emergency room fell silent. What happened next would end his career forever. The fluorescent lights of St. Mary's emergency department buzzed overhead, casting harsh shadows across the sterile white floors. It was 2:30 a.m. on a Tuesday night, and the usual chaos of the night shift was in full swing. Drunk college students stumbled through the automatic doors, elderly patients waited patiently in wheelchairs, and the constant beeping of monitors created a symphony of medical urgency that never seemed to end. Dr. James Mitchell adjusted his stethoscope for the third time that hour and glanced at his watch with growing impatience. His shift was supposed to end in 3 hours, and he was already exhausted from dealing with what he considered to be an endless parade of non-emergency cases. The last thing he wanted was another complicated situation that would keep him past his scheduled time. That's when she walked in. Dr. Sarah Williams moved slowly through the emergency room doors, her right hand pressed firmly against her chest. Her breathing was labored, and beads of sweat dotted her forehead despite the cool hospital air conditioning. She wore a simple navy blazer over a white blouse and black slacks, professional attire that seemed oddly out of place among the chaos of the ER environment at this ungodly hour. Her movements were deliberate and controlled, suggesting someone accustomed to maintaining composure under pressure, but the slight tremor in her hands and the way she had to pause every few steps told a different story. This was someone in genuine distress, fighting to maintain her dignity while battling something serious happening inside her body. At the triage desk, she waited patiently as the nurse, Kelly Thompson, looked up from her computer screen with the practiced expression of someone who had seen everything the night shift could throw at her. "What brings you in tonight, ma'am?" Kelly asked, her voice carrying the practiced efficiency of someone who processed dozens of patients every shift, most of whom probably didn't need to be there. "I'm experiencing severe chest pain," Dr. Williams said quietly, her voice steady despite her obvious discomfort. "It started about an hour ago, sharp, radiating down my left arm, accompanied by shortness of breath." Kelly's fingers flew across the keyboard, entering data with mechanical precision. "Any history of heart problems?" "No, but previous surgeries? None related to cardiac? Age? 38? 38? Kelly glanced up from her screen, taking in Dr. Williams's appearance with a quick, assessing look. Young, black, well-dressed, articulate. In her experience, people who looked like this usually came in with anxiety attacks or drug-seeking behavior, especially at this hour. She made a quick mental assessment and assigned a low-priority code to the case. "Take a seat in the waiting area," Kelly said, gesturing vaguely toward the crowded chairs. "Someone will call you when a room opens up." "How long do you think that might be?" Dr. Williams asked politely. "The pain is quite severe." "Could be a while," Kelly replied without looking up, already moving on to the next patient. "We're backed up tonight." "For the next 2.5 hours, doctor." Williams sat in the crowded waiting room, watching as patient after patient was called before her. The pain in her chest had intensified, but she maintained her composed exterior, occasionally pressing her hand to her chest when the sharp sensations became particularly intense. She watched as a young white man with what appeared to be a minor cut on his hand was called back almost immediately. An elderly white woman complaining of a headache was seen within 30 minutes. A middle-aged white businessman with chest pain, similar symptoms to her own, was rushed back within 15 minutes of arrival. Dr. Williams understood hospital protocols better than most. She knew that emergency departments operated on acuity levels, prioritizing the most critical cases first, but she also knew that unconscious bias often influenced those decisions in ways that medical staff rarely acknowledged or addressed. Her pain intensified, radiating down her arm with increasing frequency. The sharp stabbing sensation would come in waves, each one more intense than the last. She found herself gripping the armrest of her chair, trying to breathe through the discomfort while maintaining her composed exterior. Around her, the waiting room buzzed with the quiet conversations of other patients and their families. A young mother tried to calm her crying baby, while an elderly man dozed fitfully in his wheelchair. The television mounted on the wall played infomercials with the sound muted, casting flickering blue light across the faces of people who had been waiting for hours. She approached the desk again, this time speaking to a different nurse who had just come on duty for the morning shift. "Excuse me," she said softly, maintaining her professional demeanor despite her growing discomfort and frustration. "I've been waiting for over 2 hours, and my symptoms are getting progressively worse. The chest pain is intensifying." The new nurse, whose name tag read Amanda Rodriguez, didn't bother looking up from her computer screen where she was reviewing patient charts from the previous shift. "Ma'am, we see patients based on medical priority and acuity levels," Amanda said in a tone that suggested she'd given this explanation hundreds of times before. "If it was a true medical emergency, you would have been called by now. The physicians know what they're doing." "I understand triage protocols, doctor," Williams replied, her voice remaining calm despite her mounting frustration. "But chest pain in women often presents differently than in men, and the delay in proper evaluation could be dangerous if this is a cardiac event." "Please take a seat," Amanda interrupted, finally looking up with barely concealed irritation etched across her face. "We'll call you when we have an available examination room and physician. There's nothing more I can do to speed up the process." Dr. Williams returned to her seat, noting the way other patients in the waiting area carefully avoided eye contact with her. Some had clearly overheard the exchange, and she could see in their faces the uncomfortable recognition that something unfair was happening, but also their relief that it wasn't happening to them. The unspoken understanding hung in the air. Everyone knew the system wasn't fair, but as long as it wasn't affecting them personally, it was easier to look away. She pulled out her phone and considered calling someone, a colleague perhaps, or even the hospital administrator she knew personally. But something held her back. She wanted to see how this would play out, to experience firsthand what hundreds of other patients endured when they didn't have connections or influence to smooth their way. As the minutes ticked by, Dr. Williams began to understand the full scope of what was happening. This wasn't just about her individual case. It was a window into a much larger systemic problem that affected countless patients who didn't have the luxury of her position and authority. She watched the patterns unfold before her eyes. White patients with seemingly minor complaints were called back quickly. Patients who appeared to have insurance or social status received more attention from the nursing staff. Meanwhile, patients of color, the elderly, and those who appeared to be of lower socioeconomic status waited longer and received less compassionate treatment. The realization was both heartbreaking and infuriating. As chief of medicine, she was ultimately responsible for the care provided throughout the hospital, including this emergency department. How had she missed this? How many patients had suffered because of systems and attitudes she had failed to address? Finally, at 4:45 a.m., nearly 4.5 hours after her arrival, Dr. Williams was called to examination room 7. The room was small and sterile, with the familiar smell of antiseptic that permeated every corner of the hospital. She settled onto the examination table, trying to find a position that didn't exacerbate the pain that was now constant and intense. Dr. Mitchell entered 5 minutes later, chart in hand, looking more annoyed than concerned. He was a man in his early 50s with graying hair at his temples and the kind of confident demeanor that came from years of being the smartest person in most rooms he entered. His white coat was crisp and pristine. His stethoscope hung around his neck like a symbol of authority, and his overall appearance projected the image of a successful physician who was accustomed to being respected and obeyed without question. He had been working in emergency medicine for 15 years, and in that time, he had developed what he considered to be a keen ability to quickly assess patients and separate the truly sick from the worried well. He prided himself on his efficiency and his ability to move patients through the system quickly, though his definition of efficiency often meant spending minimal time with patients he deemed to be low-priority cases. "So," he said without bothering to make eye contact, his attention focused on the chart in his hands rather than the patient sitting before him. "Says here you're having chest pain. Yes, doctor, Dr. Williams began, choosing her words carefully and speaking in the measured tone she had perfected over years of difficult conversations. It's been persistent for several hours now. Sharp, stabbing pain radiating down my left arm, accompanied by shortness of breath, and Dr. Mitchell held up a hand to stop her mid-sentence, a gesture that immediately established his dominance in the interaction. How old are you? 38. Any history of drug use? The question came quickly, almost reflexively, as if it were a standard part of his assessment for patients who looked like her. Dr. Williams blinked, taken aback by the directness and seeming irrelevance of the question to her presenting symptoms. No. Alcohol consumption? Regular drinking? Occasionally, but that's not relevant to my current symptoms. Look, Dr. Mitchell interrupted, finally looking at her with barely concealed impatience and what appeared to be a pre-formed judgment about her case. Young women don't have heart attacks. What you're describing sounds like anxiety. Maybe a panic attack brought on by stress from work or personal issues. Doctor, I need you to listen to me carefully. Doctor, Williams said, maintaining her calm, professional tone, despite the growing realization that this physician had already made up his mind about her diagnosis. I'm describing classic symptoms of acute coronary syndrome, and I am listening, he said dismissively, already scribbling notes on his chart without having performed any physical examination whatsoever. And what I'm hearing is someone who's stressed, probably overworked, and having an anxiety response to whatever's going on in her personal or professional life. It happens all the time, especially with people in high-pressure jobs who don't manage stress well. His assumption that she must be in a high-pressure job was telling. He had made judgments about her based on her appearance and manner of speaking, but those judgments didn't extend to believing she could be experiencing a genuine medical emergency. She was professional enough to be taken seriously as a person, but not sick enough to be taken seriously as a patient. Dr. Williams took a deep breath, trying to maintain her composure in the face of what was clearly becoming a problematic interaction that was spiraling beyond anything she had anticipated. I understand your initial assessment, but given the severity and nature of my symptoms, along with the duration they've persisted, I'd like to request an EKG and basic cardiac enzyme tests to rule out acute coronary syndrome. Her request was specific, medically appropriate, and delivered in the kind of precise medical terminology that should have given Dr. Mitchell pause to reconsider his hasty diagnosis. But instead of taking her seriously, he actually laughed, a short, condescending sound that filled the small examination room and seemed to bounce off the sterile walls. Ma'am, I've been practicing emergency medicine for 15 years, he said with the kind of superiority that suggested he viewed her request as presumptuous and almost insulting to his expertise. I think I know the difference between a heart attack and an anxiety attack. You don't need to tell me how to do my job. So do I, she said quietly, her voice carrying an edge that Dr. Mitchell completely failed to register or take seriously. Oh, you're in the medical field. His tone was mocking now, with the kind of condescending amusement that suggested he found the very idea entertaining rather than credible. Let me guess. Nurse? Medical assistant? Maybe a pharmacy technician? Medical receptionist? Each guess revealed more about his assumptions and biases. He could envision her in a supporting role in healthcare, but not in a position of authority or expertise. She was educated enough to use medical terminology, but in his mind, that didn't translate to actual medical knowledge or the right to question his clinical judgment. Dr. Williams said nothing in response to his guessing game, but her jaw tightened slightly as she watched this man systematically dismiss not only her symptoms, but her intelligence, her professional competence, and her right to advocate for her own health care. The silence stretched between them, heavy with unspoken tension. Listen, Dr. Mitchell continued, pulling out his prescription pad with a flourish that suggested he was doing her a great favor. I'm going to prescribe you something for anxiety that should help with these episodes. Lorazepam. Take as needed for anxiety symptoms. Go home. Get some rest. Maybe consider seeing a therapist or psychiatrist for ongoing management. These episodes are usually stress-related, and they respond well to proper mental health treatment and lifestyle modifications. He tore off the prescription and handed it to her without ceremony, his body language clearly indicating that the consultation was over and that he had other, more important patients to see. The interaction had lasted less than 10 minutes, and in that time, he had dismissed her symptoms, refused appropriate diagnostic testing, and prescribed psychiatric medication for a condition he had never properly evaluated. "That's it?" Dr. Williams asked, her voice still calm but now carrying a note of disbelief that seemed to go completely over Dr. Mitchell's head. "You're not going to run any diagnostic tests? No physical examination? No EKG to rule out cardiac causes?" "That's it," Dr. Mitchell confirmed, already moving toward the door with the confidence of someone who believed he had efficiently solved another case. "The prescription will help with the anxiety symptoms. Take care now and try to manage your stress better." Next, the dismissal was complete and final. In Dr. Mitchell's mind, he had seen another anxious young woman, provided appropriate treatment, and moved efficiently on to the next case. He had no idea that he had just committed what would become one of the most consequential errors of his medical career. As Dr. Williams sat in the examination room, processing what had just happened, she could hear Dr. Mitchell in the hallway making a phone call. His voice was low, but the acoustics of the hospital corridor carried his words clearly into her room. "We've got someone in room 7 who's refusing to leave," he said into his phone, his tone suggesting this was a routine occurrence. "Typical drug-seeking behavior. Claims she's having chest pain, but it's obviously anxiety. Can you send someone up to escort her out?" Dr. Williams closed her eyes for a moment, feeling a familiar mixture of anger and sadness wash over her. This wasn't the first time she'd encountered this kind of treatment, and she knew it wouldn't be the last. But tonight, given her position and the potential consequences of this doctor's negligence, the stakes were higher than usual. 2 security guards arrived within minutes, their heavy footsteps echoing in the hallway before they appeared in her doorway. The larger of the 2, a middle-aged man with a kind face that seemed apologetic about what he was being asked to do, stepped forward. "Ma'am, we're going to need you to leave the premises," he said, his voice gentle but firm. "The doctor says you've been seen and treated." "I understand, doctor," Williams said, rising slowly from the examination table. "I'll leave." As she stood, the motion caused her hospital ID badge, which had been tucked discreetly inside her blazer pocket, to slip out and clatter to the floor with a metallic sound that seemed unnaturally loud in the quiet room. The security guard bent down to pick it up, and as he read the information printed on the badge, his face went completely pale. "Dr. Sarah Williams, Chief of Medicine," he read aloud, his voice barely above a whisper. The room fell completely silent. The second security guard stepped closer, looking over his colleague's shoulder at the badge. Dr. Mitchell, who had been halfway down the hallway, froze mid-step when he heard the guard's words. "Did you just say Chief of Medicine?" the second security guard asked, his voice shaking slightly with the realization of what this meant. Dr. Williams calmly took her badge back and clipped it to the outside of her blazer where it belonged. For the first time since entering the emergency department, she stood to her full height, and her presence seemed to fill the room with an authority that had been invisible moments before. "Yes," she said simply, her voice carrying a quiet strength that commanded immediate attention. "Dr. Sarah Williams, Chief of Medicine at St. Mary's Medical Center. And for the past 4.5 hours, I've been a patient in my own emergency department." Dr. Mitchell turned around slowly, his face draining of all color as the full magnitude of the situation began to dawn on him. "Dr. Williams, I didn't know. I had no idea that you were—" "No," she said, her voice still calm but now carrying unmistakable authority. "You didn't know because you didn't listen. You saw a young black woman in your emergency room and immediately made assumptions about my education, my intelligence, my medical knowledge, and my right to quality health care. Word spread through the emergency department like wildfire. Within minutes, nurses, residents, and attending physicians began appearing in the hallway outside room 7, drawn by whispered conversations and the electric tension that now permeated the air. Dr. Patricia Chen, the department head, and Dr. Mitchell's direct supervisor came rushing into the room, Her face flushed with a combination of embarrassment and panic. "Dr. Williams, I'm so terribly sorry," she said, slightly out of breath from her rush to get there. "If I had known you were here as a patient, this never would have happened. We would have, but you didn't know," Dr. Williams interrupted, her voice cutting through Dr. Chen's stammered apology. Just like Dr. Mitchell didn't know. And that's exactly the problem. The question we need to ask ourselves is this: how many other patients receive this same dismissive treatment when I'm not here to witness it? Dr. Mitchell stood frozen against the far wall, watching his career crumble before his eyes. His 15 years of experience, his medical degree, his position in the hospital, all of it suddenly seemed meaningless in the face of this catastrophic error in judgment. "Dr. Mitchell," Dr. Williams continued, turning her attention to him directly, "you dismissed my symptoms without conducting a proper examination. You refused to order basic diagnostic tests that are standard protocol for chest pain. You made assumptions about my mental state and prescribed psychiatric medication for symptoms you never properly evaluated. And finally, you had me removed from the premises by security." The room was deadly quiet, except for the soft beeping of medical equipment in adjacent rooms. If I had actually been having a heart attack, which, for the record, I was not, but your job was to make that determination through proper medical evaluation, your negligence could have killed me. Over the next several days, Dr. Williams conducted a thorough and systematic review of the emergency department's practices and protocols. What she discovered was disturbing but unfortunately not surprising: a clear pattern of racial bias in patient care that manifested in longer wait times for minorities, more frequent dismissal of symptoms, and a significant disparity in the quality and thoroughness of treatment provided. She reviewed hundreds of cases, interviewed staff members at all levels, and analyzed data that painted a picture of systemic discrimination that had been hiding in plain sight for years. Dr. Mitchell's case wasn't an isolated incident. It was simply the most dramatic example of a much larger problem. The review revealed that Black women, in particular, were significantly more likely to have their pain dismissed, their symptoms attributed to mental health issues, and their requests for specific tests or treatments denied. The data was overwhelming and undeniable. Dr. Mitchell's case became the catalyst for a complete overhaul of the department's protocols and procedures. He was immediately suspended pending a full investigation, and his medical license was reviewed by the state medical board. Several other staff members who had shown similar patterns of discriminatory behavior were also placed under review. Dr. Williams used her experience as both a patient and a physician to implement sweeping changes throughout the hospital system. She established mandatory unconscious bias training for all medical staff, from nurses and residents to attending physicians and department heads. New protocols were put in place for the evaluation of chest pain that removed subjective assessments based on age, race, or appearance. Every patient presenting with cardiac symptoms would receive the same standard battery of tests regardless of demographics. She also created a patient advocacy program specifically designed to address healthcare disparities and ensure that all patients received equitable treatment. The program included patient representatives who could intervene when bias was suspected, and a formal complaint process that would be taken seriously at the highest levels of hospital administration. "This isn't about revenge or punishment," she told the hospital board during an emergency meeting called to address the situation. "This is about ensuring that every single patient who walks through our doors receives the same level of care, respect, and medical attention regardless of their race, age, gender, or socioeconomic status." The incident with Dr. Mitchell didn't stay contained within the walls of St. Mary's Medical Center. Word of what had happened spread throughout the medical community, sparking conversations about racial bias in healthcare that had been long overdue. Medical schools began incorporating Dr. Williams's experience into their curricula as a case study in unconscious bias and its potentially deadly consequences. Professional medical organizations used her story to advocate for better training and more diverse hiring practices. Dr. Mitchell never returned to St. Mary's, and his medical license was ultimately suspended for 2 years. His dismissive treatment of Dr. Williams became a cautionary tale told in hospitals across the country, a stark reminder that bias in medicine isn't just morally wrong. It can literally be a matter of life and death. For Dr. Williams, the experience was both professionally vindicating and personally painful. As someone who had dedicated her entire career to medicine and patient care, being on the receiving end of such treatment was a harsh reminder of the obstacles that still existed for people who looked like her. But it also strengthened her resolve to use her position and influence to create lasting change. She became a national advocate for healthcare equity, speaking at conferences and working with policymakers to address systemic racism in medical care. "The most dangerous assumption in medicine," she often said in her speeches, "is that we know who deserves our best care based on how they look or where we think they come from. Every patient deserves to be heard, respected, and treated with the same level of professional attention." Years later, the changes implemented at St. Mary's had become a model for hospitals across the country. Patient satisfaction scores among minority populations improved dramatically, and the hospital became known as a leader in equitable healthcare delivery. Dr. Williams continued her work as chief of medicine, but she also took on the additional role of director of health equity, a position created specifically to address the issues her experience had brought to light. Under her leadership, the hospital's policies and practices became a template for addressing healthcare disparities. The emergency department where her ordeal took place was completely transformed. New staff, new protocols, and a new culture of respect and equity replaced the old ways of doing things. Patient advocates were stationed in the ER around the clock, and regular training sessions ensured that the lessons learned from Dr. Williams's experience would never be forgotten. And that's how one doctor's prejudice and one woman's courage led to the transformation of an entire medical system. Sometimes the most powerful lessons come from the most painful experiences, and sometimes the people we least expect to teach us end up being our greatest teachers. Dr. Sarah Williams's story is a reminder that bias exists everywhere, even in places where we least expect it and where the consequences can be most severe. But it's also a testament to the power of standing up for what's right, even when, especially when, you're the one being wronged. The moral of this story is clear. Never judge someone by your assumptions about who they are or what they're worth. In medicine, as in life, every person deserves to be treated with dignity, respect, and the highest standard of care. Her experience changed not just one hospital, but sparked a movement toward more equitable healthcare that continues to this day. And while the work is far from over, Dr. Williams's courage in that emergency room on one difficult night helped ensure that future patients won't have to endure what she did. What would you have done in Dr. Williams's position? How do you think we can continue to address bias in healthcare and other areas of life? Let us know in the comments below. And remember, every voice matters in the fight for equality and justice. If you enjoyed this story of courage, justice, and positive change, make sure to subscribe to our channel and hit that notification bell. We bring you true stories of resilience and transformation that will inspire and motivate you to make a difference in your own life and community. Thanks for watching, and I'll see you in the next one.